Welcome to the Global Webinar Series, Current Knowledge and Future Directions in Psoriasis. Okay, so today this is our fourth webinar, and we are going to talk about how to organize our psoriasis clinics in the future. We have to thank IPC Global Webinar sponsors who are Abby and Lily and company. So thanks for the possibility to have this webinar again with you. This webinar will last like 16 minutes. It's going to be recorded, all the complete webinar. The audio is muted. Please ask questions through the questions and answers. And recorded will be available at psoriasiscouncil.org. So I want to let you know a very little about the International Psoriasis Council. I am Claudia de la Cruz. I am from Clínica Dermatology, Santiago, Chile, and I'm an IPC board member. And I'm very pleased to tell you about what this organization is. It was founded in 2004. It's led by dermatologists, volunteer global nonprofit organization. We have more than 100 psoriasis experts in our network. So we really have been working very hard along all these years in education. And this is what we want to bring to you this morning or afternoon, depending where you are from. Which is our vision, mainly that we want a world free of psoriasis. Our psoriasis patients, no matter where they live in the world, no matter how complex their disease or their symptoms are, we really think that they should have access to the best care available for them, and that ultimately a world without psoriasis is possible. And we have been working very hard to get this for our patients. So our mission is to improve the care of people with psoriasis worldwide through research, education, and advocacy. We have been working a lot in different regions of the world, 155 board members and counselors representing 36 countries. You see in this map, we see how huge this organization is. Of course, we still need to reach to some regions, but we are working very hard to get to all the world, literally. So our key areas of focus are the access to care, research, medical education, and global outreach. We have a lot in our knowledge center online. So we invite you to visit our platforms and visit, for example, the Take 10 video series, the on-demand symposium, video library. We have a calendar of events where you can really look what the best interest for you are the events or meetings that we have for you. We have Congress reports, fellowship programs, psoriasis review newsletter, and our COVID research center. So visit psoriasiscouncil.org, and please also check our social medias like Instagram, Facebook, follow us, and also ask for our newsletters, because they will be always letting you know all we have been doing in the last months or year. So mark your calendars for these upcoming webinars. We still have in May 2022 how to prepare for another pandemic. And there are videos of previous webinars available on IPC website, immunology, the perspective of comorbidities and early intervention, personalized medicine psoriasis, with a focus on registry, big data, and artificial intelligence. So you can reach for them, and of course they will be very useful for you, and we really hope to. So this is our number 4 webinar series. We are going to have our really great lecturers today, which are Joe Lambert from Ghent University Hospital in Belgium and Alexander Navarrini, University Hospital of Basel in Basel, Switzerland. The agenda for today is going to be Psoriasis Clinics Now and in the Future by Joe Lambert, Telemedicine Now and in the Future by Alexander Navarrini, and then we're going to have a questions and answers and closing comments at the end of our session. please remind you to do your questions and answer by the chat. So, welcome, Joe, and let's hear what you have to say to us today.
Thank you so much, Claudia. I hope you can all hear me quite well. Okay. Well, it's my honor to be able to talk to you about this exciting topic on how to organize our clinics. Amanda is going to share my screen and also proceed with the slides. So I choose actually to talk to you, since we are a community of psoriasis experts, to talk to you how we work in Ghent and the efforts we have made to improve the management of our psoriasis clinics. And what I really would like is that we have a lively discussion on what I am. Can I have the next slide? Yeah, so, yeah, sorry, slide before. So in Ghent, so I work in a big hospital. I work in the second biggest hospital, the University Hospital of Belgium. And in the Department of Dermatology, of course, we see all kinds of patients, all kinds of interventions that we do there, 31 consultations a year. And the first thing I decided whenever the hospital gave us the chance to do that is to take away our psoriasis consultation to a remote peripheral building, because the hospital saw that many patients are anxious to find parking, to find a way to the right spot in a very complex environment. So that's where we do on the right-hand side now 2 half days a week of psoriasis clinic, which we call So Plus. So we see about 1,600, or we have contacts with 1,600 consultations a year. We also published the way we work a few years ago, but we have been working in So Plus since 2012. Next slide. A big change, so what So Plus is about, I was really intrigued by the major breakthrough we have had in psoriasis insights, not only pathogenesis, but also on the comorbidities, on the quality of life, on the burden of disease, on what is a severe patient, and how we should surround these patients. And we believe that working in the very classical way, the blue way, the classical way in healthcare, that a patient goes through a very siloed journey, that he has to find his way to the right specialist. So in So Plus, we say the patient more and more should be in the lead, and a team is welcoming him or her face-to-face or virtual. And actually, there is a continuity of contact between the team and the patient. So we not only we see patients in the clinic, but continuously we have a form of contact with our patients. So the patient is seen as an active partner. He has some homework to do for us every now and then. And we also have made sure that our team is multidisciplinary. So this is So Plus. You can have the next slide. So rather than delivering patients a very serial room after another, we made patients the owner of their own rooms in the care path, and instead we circulate the providers around the patient. This is a statement coming from another publication, but which resonates very well with how we work. Yes, next slide. And you know, at a certain point in 2012, when we started working like this, and the months thereafter, my colleague said, how do you know, with all the resources you use, you use 2 nurses, 1 doctor, you have contact in between, you have an administrative person, which takes a lot of the questions. How do you know that it's worthwhile to invest so much in your patients, resource-wise? And that's where I came to the concept of value-based healthcare, a concept of Michael Porter and Elizabeth Theisberg, which you see below on the right side, which actually puts value for the patient very central. And you can only deliver value, they say, if you cover the full cycle of care for your patients in all its aspects. So also for psoriasis in terms of tackling the comorbidities, looking at the quality of life. So you need to organize yourself in an integrated practice unit, as they call it. And to show that you bring value, you need to start measuring outcomes. And of course, you also measure the cost, because it's always a balance between having the best outcomes at a reasonable cost. But when you measure the costs, you can continuously improve yourself, because you have a kind of check if what you are investing in your patients is really worthwhile and leading to the best value. They go even further. Rather than getting a fee each time you see a patient, they say, why not look on a yearly basis and say, this is a bundled sum you get for your patients to follow them up in a year's time. And it's up to you to decide if you don't see them or see them 5 times. So you get a fee or a bundled payment for this. Good, next slide. And this equation is very important in value-based healthcare. Value is equaling the outcomes you receive when doing your care over the cost it takes to achieve those outcomes. And let's focus on the outcomes first. You can click and then go to the next slide. Yes, next. So let's see where in literature, this is what we did the last years, and these are new data and confidential data, not published yet. Let's see where the patient voice has helped to make care more appropriate. Let's look in literature where people have been looking to the field of outcomes, which outcomes are important, but we only took those studies where also the patient had a voice. So we call it Exploring Value in Psoriasis. We did a systematic review on patient relevant outcomes. So what is relevant to check? And also the patient was sitting in the teams that decided that. It's interesting what comes out. You can click further. What comes out is many studies. The world of outcomes has, of course, boomed because many clinical trials have been performed which needed those outcomes and the instruments to measure them. And in the end, we had a lot of study, but we came up with 23 patient-relevant outcomes, which we grouped into 4 core areas. And if you would start measuring those outcomes, in your clinical care path, this might aid the transition to a value-based healthcare approach because you measure value. Next slide. So these are the outcomes that you see here, the 23 ones. Noteworthy is that, of course, physical outcomes like complete clearance, almost complete clearance, treatment efficacy were reported very often in literature. And let's look at, for instance, emotional well-being. This is much less reported. Having the feeling I control my disease is also less reported on. But nevertheless, we took all these, the 23, and next slide, we presented those to our own patients. So first we did a modified nominal group technique with 8 patients. We discussed an evening discussion. What do you think about these outcomes? Are they important? And they say our Ghent patients ranked them in order of importance. Next slide. And well, actually, the percentages are a bit different than in literature. Top is symptom control. So patient finds it's very important to have symptom control, of course, treatment efficacy. But for instance, having confidence in the care you receive and having the feeling I control my disease were ranked very highly. So this is really a perception from the patient side, which was ranked very high and didn't come out of the systematic review. On the other hand, things that we work on a lot, like trying to raise the awareness of comorbidities, was ranked very low, which shows that our patients are not really bothered with the comorbidities, although from a medical point of view, we think this is very important, and it is very important. So bringing value is taking into account what the patient finds very important, but not neglecting what you as a medical doctor also find important on the long run for a patient. Also, how much the care costs didn't matter to our patients, because Belgium is, of course, a very well taken care of social health, has a very good social healthcare system, and the patients hardly have to pay anything for their care. This might be very different in other countries. Okay, so we have a kind of set of outcomes here, next slide, that we want to work around, and we want to get the best results in those outcomes. So how did we get organized? Next slide. So we organized PSO+, yeah, next slide, in our integrated practice unit. And actually what you might also be doing, and I'm glad to hear about that, is we have a very structured approach in our consultation. You see all the blocks that we really click and tackle in order to get the best information around the patient that is sitting in front of you. We call it our PSO+ 2.0 because we have been updating it already. So a structured electronic health record collecting all of the data. Next slide. We also have, and this is new, a patient platform, a kind of protected area, a virtual area, where we can send, before consultation, questionnaires to the patient, but also little assignments like go to the GP to have a blood check for cholesterol, for instance. But it is also a system where the patient can book his consultation himself. We also give advice through this patient platform in between consultations. So whenever a patient is anxious about something, we give advice through this protected system. It's also a learning environment where we put educational videos, and you can click, because I have some examples. So we explain what psoriasis is. We explain about, you can click twice, about the comorbidities, about possible treatments, and also about how PSO+ is an added value for them. Next. So this is again our building. So in this system, a patient comes in, there is some pre-information that we have because the patient filled out things at home. And each consultation, what we do is we check whether we are ambitious enough. So you see here a national consensus that we made with Belgian psoriasis expert. And we think it's important that each consultation you check whether the disease is under control, of course, whether the patient well-being is okay, whether the treatment is not too burdensome, and whether the comorbidities have been detected and referred for. I will not go into detail, you can read this publication, but whenever one of the outcomes in this treat to target environment is not taken care of, this is for us a trigger to add something to the treatment, to change something in the management. So it keeps us very awake, I would say, to get the best results in our patients. Next. We also have a predefined path to other specialists because these are expected visits. So we have reserved spots in the other departments. For instance, with the rheumatologist, we can book every Tuesday, we can book consultations. It's open only for dermatology. We have a psychologist also with open slots only for dermatology because these are expected visits. It always fills to the fullest, so it's foreseen and it's always full. We also have a back and forth communication with the GP to tackle, amongst others, the metabolic syndrome problems. Although the patient doesn't find this very important, but we think it's important. So this is taken into account. Next slide. So this is how we try to achieve the best outcomes through our organization. And I'm very curious how you get organized to achieve and to tackle the complexity of psoriasis to get the best value. Then, of course, there's the denominator of this equation, which is the costs. And you can click and even click one more. You might say, well, this must cost a lot what this lady is doing with her team. So I don't know if my hospital would allow 2 nurses, 1 doctor, contact, which is not paid in between consultations, etc. Well, let's have a look how we deal with that. Okay, next. what an economist has been doing the last years, so we have a collaboration with a business school here in Ghent. They have started to apply the technique of time-driven activity-based costing. So what is the true cost of the way we are working? And really this comes down to measuring how many minutes each step of our care path takes. And you can see here an example of it. And it was calculated that only the dermatology part, so not even the referral departments, what we are doing costs on average 72 euros to get the value we expect to have. And what you also see here, left bottom, is that a doctor costs 5 times as much as the salary of a doctor, is 5 times as much as the one of a nurse and the one of a secretary. So we have all reason to use the doctor as little as possible and to promote contact of the patients with the nurse. I will show you how we do that. Next. So we believe PSO+ generates the best value, and we know it costs a lot, so we can only try to limit the cost because we don't want to change the way we are working. But we need to limit the costs in clever ways. And we also published on cost drivers in healthcare systems. You can see that below. Next slide. Okay. So first thing we said, would it be as good to work with only one nurse, because personnel costs a lot. And so the economist, Erin, she sat down and was calculating. But what happens when I only have one nurse is that I have to sometimes wait, and actually the waiting time in between 2 patients, because she was not ready yet, also costs a lot. Okay, I can do other things, but practically spoken, it would be better if I also see patients in that time. And actually it was economically much better to work with 2 nurses, so because my waiting time was going down. It's very interesting to do things like that. So we continue working with 2 nurses. That was one conclusion. Next slide. So this is how we work. We have 2 nurses. They work 15 minutes apart. So nurse 2 sees the first patient, and 15 minutes later, nurse 1 sees the second patient, which means that I get fueled, or the dermatologist gets fueled with patients every 15 minutes. So the nurse takes 30 minutes and I take 15 minutes. Okay, this is how we started, very basic. Yeah, you can click. But we said not all patients are the same. Why don't we try to be more efficient? You can click. If we make focus points, we all know you can click that we have new patients, but that we also have known patients, and it takes another form of attention and preparation maybe. So we started having slots only for new patients and only for known patients. And next, we also saw that there are patients, you can click twice actually, that only come to get a refill for their biologicals, and this really takes little time also with the nurse, and I could in the same time period see 3 or even 4 patients there. And there is also the possibility for a PSO on demand, so booked by the patient, because he has an alarm sign for something. So those consultations are also shorter because the patient is already very grateful that he can be seen by us. So by making more clever subdivisions of our appointment system, we could see 25% more patients with the same crew. So this is more efficacious or more efficient cost-wise. Then came in the time of the teleconsultations, was since the pandemic even we got a fee for that. So before that, we didn't get a fee. In Belgium, we get 17 euro for a teleconsultation. And you can click 1, 2, 3 times. So whenever I had a spare time moment, I booked a teleconsultation. I also booked a maybe a PSO on-demand physical consultation could become a teleconsultation with the same value for the patient. But what I would like to point out here is that if you look at teleconsultation doctor in the table, it sometimes takes a lot of time, and it's not really less costly to do a teleconsultation in our hands than seeing a patient live. So there I would prefer to keep on doing live consultations, or also look where maybe a teleconsultation can be done by a nurse with the same value for the patient. Okay, you can go to the next slide. So this is an optimization system. I told you that we also have an administrative person reading the messages from the patients in between. And it's amazing how much administrative burden the biologicals bring along. There's a lot of paperwork, at least in Belgium, prescriptions that have run out of date, etc. But also she receives a lot of calls and messages to get an appointment. So we calculated if we could move to the fact that the patients go for an online scheduling system. So like you do in a restaurant, you book your own appointment. This could already save us 16,000 euros in personnel cost per year. Okay, next. So we integrated, or we try to integrate this now to go to an online booking system, very well explaining what the different consultations types are. With regard to messages about reimbursement forms for biologicals, I have no solution yet. In the end, I have to do the signing, etc. Should I make it a teleconsultation or what? I have no, or could it be done by a nurse? But then the nurse doesn't have the authority to prescribe. So this is also a point where optimization is possible. Next slide. Good. Actually, what I have been showing, I have come to the end, is something I would like to discuss with you. So what I have been showing is that we have been structuring our patient files to grasp all aspects of the psoriasis patient. We do this since 2012, so we have a full image of the patient, and actually it's the nurse who grasps all this information. And when the patients come to me, the last 15 minutes, I already have a kind of profile of my patient, and I immediately start the clinical examination, and I measure the PASI scores myself. This was a question in the chat. And I start the management for my patient. So we have predefined or pre-reserved referral paths to other specialists that we need anyway. If possible, we let the nurses help. We try to motivate our patients to help add information and take up active responsibility through the patient platform. And we know we are more costly, but we hope to show in a trial that will start soon. We will start measuring our 21 outcomes. We hope that we can show that the secondary savings we have actually are much higher than the higher costs that we are taking. And this concept is value-based healthcare, could easily be copy-pasted to atopic dermatitis, hidradenitis, autoimmune, blistering diseases, any chronic immune disease of the skin that you can imagine. And last slide, you can click twice. Yeah, you can click. I want to thank my team, these young people I have recruited like 4 or 5 years ago. These are the 3 left ones are my 3 PhD students. Right-hand side are the more senior postdocs in the team that are really passionate about value-based healthcare and also biologicals. And we have a very nice collaboration with Vlerick Business School in Belgium. We need the economists for this. And partially, we also get funding next to government funding. We get also Janssen and Novartis funding. Thank you very much.
Thank you, Joe. This was a wonderful presentation. We are receiving already many questions and answers through the chat. So everyone, let's wait until the end. We're going to ask those questions to Joe at the end, and keep writing all your questions. So Thank you, Joe, again. And let's welcome Alexander and let's listen what he has to tell us about telemedicine.
Thank you for the introduction. Now, you need to give me permission so that I can share my screen. Oh, perfect. Thank you. You just did that. So, bit of latency in the network. Do you see my slides?
Yes, we do.
I assume that, yes. Okay, so then I will now talk about telemedicine, and it's great. I think it connects very well because if you give the patients the opportunity to fill out some patient-reported outcomes, for example, then basically that's a kind of indirect telemedicine as well, and perhaps cleverer than what we do right now, completely remotely in some ways. So there's a global undersupply of dermatology services. Patients have to wait up to 4 months for an appointment with a dermatologist, typically, at least in Basel, that's the case now, or even up to 5 months. And often patients have to travel long distances, they lose a lot of time. And even when they stay with family physicians, often the diagnosis is delayed. There's going to be a further shortage of dermatologists, at least in Germany. I'm not sure about other countries, but it is in Switzerland, it's definitely also the case. So 2/3 of German dermatologists in practice are of advanced youth. So they will retire at some point. And young ones are often going directly into aesthetics, which is a major drain of our field. But the demand for dermatological services is not dwindling. So indeed, 25% of the adult population have an annual need for dermatologic treatment. And it's been said and studied that many of these cases can be treated by teledermatology. The percentage varies a little bit by specialist and opinion, but it's clear that it's quite a huge part that can at least be starting to address in teledermatology. The question is whether psoriasis belongs to that type of diagnosis that can be treated with teledermatology. When we started with teledermatology, or even before that, we asked patients whether they want digital services. You know, Switzerland's not it's not always very modern, so some people are very conservative. So we thought it's time to ask them, and indeed, 3/4 wanted digital services as part of the medical consultation, and indeed they wanted digital prescriptions, registration forms, as Jo hands out electronically to patients, obviously, and the biggest wish, they want to make appointments online. And there we are in a bottleneck with our hospital IT, because that's not always so easy to implement, but it's definitely something that's extremely useful for patients and avoids the constant calling and moving around of appointments. Only 1/3 wanted actually teledermatology. But the ones that did want it, they were even happy to pay for teledermatology consultations by themselves. So in Switzerland, it's actually quite different to Belgium. So people do have to pay for medical services quite a bit out of their own pocket. So that's, many have to pay 2,000 to 3,000 euros per year in addition to their insurance to get medical treatment. And if they get a biologics, it's even actually more. So of course, the teledermatology was also rising during the pandemic. It's clear that these are some numbers of a company that went up to the thousands during the pandemic, and the email inbox was full of teleconsultations. And also teledermatology is really the fastest growing area of telemedicine in the world. It's just very useful. It's also obvious for patients. They can just send in a picture and they can then get it evaluated. So you can see the huge growth that is expected from the year 2016 to year 2027. Amazing. And that's also why big companies are now investing in teledermatology, including Google. Well, what's the best age for teledermatology? You see, it's actually quite interesting that many parents, if they can't go directly to the doctor, they will send pictures of their child to the dermatologist. So that's even the highest group number-wise. And then you have teenagers that don't use teledermatology so much. So also something that's a little bit counterintuitive, actually. And then you have the whole middle age. Many people use it. And then, of course, it's just the seniors are not technologically well versed. So, of course, they will not use it so much. So there's two methods of teledermatology that we have to differentiate. One is store and forward technique, and the other is live video conferencing. And they are very, very much different to each other. So store and forward means that the patient makes some pictures, fills in some questionnaires, puts in the history data, so writes, basically like an email. And then the dermatologist can answer it at his own time. So you don't have to make an appointment, for example. With video conferencing, it's very different. Video conferencing really tries to replace the in-person consultation. And for that, of course, you have to free up time in your schedule. So it's actually a complicated in-person consultation. It's good for patients. They don't have to leave their homes. They have that advantage. But then there's also some disadvantages. So video has less resolution. Often people it's a little bit awkward to show the skin on the video. And also you can imagine that people feel uncomfortable undressing in front of a video camera that transmits the pictures of their body over the internet. So that is not always what people like. So Switzerland is mostly store and forward that we use in teledermatology. So a patient detects a skin problem, seeks help with a service. Dermatologist carries out the diagnosis, prescribes treatment and medication, and the pharmacist that the patient has selected previously, so pharmacy close to their home, they send out the medication directly, and then the therapy can be started. And of course, when we continue, prescriptions works the same way. So let's see whether psoriasis fulfills the criteria for a dermatosis that can be treated with teledermatology. Well, a good teledermatosis should have unambiguous visual features. You must be able to identify it directly. You should be able to make the diagnosis without taking a biopsy or a huge amount of labs. The differential diagnosis should be relatively low risk in case you're wrong with the diagnosis. And the treatments that are available should be non-toxic, at least in part, that nothing can go wrong with the treatment. And there should be some clear treatment algorithms. And then, so that these criteria are all fulfilled. Then question marks are, a good teledermatosis shouldn't have features with low visibility. And for example, scalp psoriasis indeed is often covered by hair. It's very difficult to make good pictures of plaques in the hair. That's definitely a disadvantage. And yes, there are neoplastic, that means cancer or infectious mimickers, shouldn't be in the foreground for a good teledermatosis, and indeed some very rare differential diagnoses are indeed neoplastic, so mycosis fungoides, for example. And yes, it shouldn't have irreversible consequences. Psoriasis itself doesn't have that, but psoriatic arthritis definitely has irreversible consequences. If it's left untreated for a while, it's destructive for the joints. Then features of psoriasis that can be diagnosed easily with teledermatology are here in green. So the erythema can be often not seen so easily, depending on the lighting. But the scaling is nicely visible. Also the infiltration that is felt typically, it's not so easily identifiable on pictures typically. And then the regions that are highlighted in green, they can be photographed easily, but then there's quite a few that are difficult to photograph for patients, so they need somebody to help them. And the symptoms, however, that can be easily interrogated with these questionnaires that can be sent to the patients: itching, pain, production of scales, functional impairment and depression, quality of life impairment, other patient-reported outcomes such as the goals for therapy. That's very useful and can be done. And then collection of information on disease-modifying factors like extrinsic risk factors, that can also be done easily with questionnaires. However, to interrogate, for example, metabolic syndrome, obesity, and so on, for many of these, you do need some measurements that can't be done directly by the patient himself without seeing you. And then comorbidities, psoriatic arthritis, the PEST score, and autoimmune conditions. So there's, yes, a plus and minuses are there definitely. So can we treat psoriasis with teledermatology? Well, we actually got the task from the IPC to make a statement on teledermatology for psoriasis, and that's exactly what we discussed. So first, whether it can be diagnosed and managed with teledermatology, and then whether we can treat it with teledermatology. We can discuss afterwards what your opinion is, and I'm sure the opinion might differ. So would you prescribe all these with teledermatology without ever seeing the patient? Many of us perhaps wouldn't, except for topicals. I believe with topicals, we might have a majority of people saying, okay, we can give topicals for a while, should be possible. Phototherapy is obviously, due to the device, that's not done with teledermatology. And then there's a few of the drugs that's the ones that really are the safest, basically, that some of us would prescribe with teledermatology. Also, it's been studied whether online teledermatologic treatment of psoriasis actually works, as well as in-person consultation. And that's been done by Professor Armstrong from the US already in 2019. So they had a cohort that was randomized after the first consultation. I think that's important to mention. So basically the continuation of treatment was measured, was evaluated in that trial. So either on the left, I'm not sure whether you can see my pointer, but either in-person care or online teledermatologic care was evaluated, as shown here. And here you had 3 monthly assessments were done and visits with the patient online or in person. And when we checked the PASI, then indeed the mean change in the PASI score wasn't different between the two strategies, which is nice to see. So basically the online treatment of psoriasis after the first consultation actually works very well. And then also psychological care. So in that cohort also a psychological care model was evaluated, and that was also well functioning for reducing functional impairment and depressive symptoms in psoriasis patients. We do have machine learning now available to measure, for example, the PASI score, or at least the area that is affected, also for pustular psoriasis. That all works very well. So this will be a decision support tool in teledermatology and also in person. Patients in the one service that we use are really happy with the teledermatologic service. And we should also be aware, as dermatologists at least, that with these AI tools, we are in slight danger of being A, supported by AI, and B, possibly replaced in some situations. So family physicians and nurses that were supported with the Google AI system for diagnosis. So this is now not psoriasis anymore. This is really diagnosis of skin disease. And they had indeed an improvement in their ability to diagnose disease. And they also felt a lot more confident when they got the AI to support them in the diagnosis. So possibly there will be kind of informal dermatologist situations that don't involve the dermatologist anymore. And I think that's something that we just have to face. That's going to be coming up soon. So, for example, an app might say, okay, this lesion has a more than 80% chance of healing completely after 4 weeks of daily calcipotriol and betamethasone. That would be a nice prediction. Let's see whether we get there sometime. Or, for example, the patient has palmoplantar psoriasis. That's what the resident might say. And then the senior physician will say, okay, did you rule out mycosis? And was the diagnosis confirmed with the app? We'll see whether we ever get that knee-jerk reaction and really depend on the computer so much. So it will be interesting to see whether we can use teledermatology to catch the psoriatic march early with the comorbidities. I'm not surprised that people in your statistic actually weren't worried about the comorbidities, because they typically aren't. That's a problem. We need to make them aware. And it's really a good opportunity to synergize with internal medicine and other specialties. And with that, I'm finished with the conclusions here, and perhaps we can discuss.
Thank you, Alexander. It's been a great presentation. Of course, we have a lot of questions from our audience. So let's check on them. Let's begin with Joe's question first.
Yeah, you can read it.
Okay.
If you like, yeah.
Okay. So Rahish, he asked, here's one of the first questions. Let me take a minute. So from Rahesh, he says, Professor Lambert, have you been able to demonstrate with any data that managing the psoriasis has an impact on reducing the comorbidities?
Well, that's exactly what we are currently measuring. It's part of showing that our approach brings value, but I don't have any final results of that yet. I would say anecdotal. I see patients in front of me that definitely get there. And in my experience, if you treat the psoriasis well, only then will the patients have the energy to also tackle the comorbidities like obesity, for instance.
Okay, and Delia Ibanez, she wants to ask, she says, so interesting your presentation about the time of each patient step by step. How do you manage this organization with pediatric patients? Do you have for pediatrics too? In general, they need more time, some toys or tools, short stories. What should be your tip for this?
A general tip, I don't see children myself. It's my colleague who does pediatric dermatology and also the psoriasis cases in children. A tip is it's only until you measure what is really happening in the process part of the patients coming to your clinic that you will become aware of the idle times that are sitting there and that can be used for very useful things like education or filling out questionnaires. It's amazing how we haven't been using idle time during the parts that our patients are doing, and also the homework they can do.
Okay. And Lucas, he wants to ask, as time is always a matter of travel during psoriasis visits, how do you usually gather patient-reported outcomes in your daily practice? Is it during the nurse visit, virtual apps, or in advanced questionnaires?
Mm-hmm. So as the time with me has to be as short as possible, because I am the most expensive player in that team, all the information is sitting in front of me when the patient enters. So I never measure any outcome, only PASI scores, the physical outcomes I do measure. So everything is either collected at the homes of the patients, in the waiting room, yeah, and a bit, I would say, checked by the nurse, controlled by the nurse if they really filled it out quite well, so that all the information is there. So try to motivate your patients that it is important, because they ask, do I need to fill this out again? I did it last time. And then we explain, no, it's a reflection of what has happened the last 4 weeks or the last week. So it's a growing insight that also is seen in our patients.
Thank you, Joe. We have also some questions for Alexander. Najib does, he mentions teledermatology is the best solution for sub-Saharan countries where there is a lack of specialists. I would say that there's a lack of specialists in many regions of the world. For example, I live in Chile and we also have lack of specialists. So what can you comment us on that, please, Alexander?
Yes, that's absolutely true. That was also the motivation of the PASSION project that we are currently pursuing in Madagascar and Tanzania. So this is not for psoriasis basically, but for pediatric dermatology. That many skin conditions like scalp, mycosis, atopic dermatitis, and so on, they have a prevalence of 10% and plus in many African countries. So what we do is actually, make a free teledermatology service that is localized in the different countries. And we try to successively replace the humans with an AI. This is so the clinical trial basically is running both human-derived teledermatology and the AI at the same time. And then as soon as the AI kind of reaches the level that is needed, then we try to replace that, because humans with the loads of the patients for free can't be easily handled. So we hope that project will be successful, because indeed, without teledermatology, I don't think we'll have the possibility to increase the number of specialists quickly that are needed in sub-Saharan Africa and some other countries.
Yeah, and how do you manage the quality of the images for teledermatologists? Like when you were talking about Tanzania, for example, or in many other countries where the quality of the images depends on what the patient has to submit to these platforms. So how do you manage this?
Well, actually, the images that people submit are typically not of inferior quality. And kind of surprisingly, when you look at countries, for example, Madagascar or Tanzania, people do nowadays have phones that have cameras that make photos that are easily evaluated by us. And if we're talking about AI, the thing is that AI makes the diagnosis on such pictures with a resolution of 512 times 512. That is a very low resolution, and still it's very good. So basically, that will not be a problem. And indeed, the connection in all the populated areas with smartphones, with the phone network, is there. That's quite incredible for somebody who doesn't know the countries, but it's actually quite intuitive. People want to communicate.
Well, this is very important, because, of course, this means that all around the world you can use this teledermatology because it's going to be a really, really useful platform. We have been using it in Chile, but not as much as in many other regions. And I wanted to ask you, what do you think about telementoring? Because we have been talking about the patients, teledermatology, but have you ever experienced telementoring as a tool that can help to educate other doctors or dermatologists in the treatment of psoriasis?
I would be very open to that. I have just seen some websites where, you know, an unending number of specialists can just chat and about some cases, but that's kind of commercial, so I'm a bit wary about that. I'm not sure whether Jo has experience with that.
It can definitely be used. We use it for our patients, because health literacy, raising health literacy is also a very important point, and having videos that are quality assured is definitely something that is needed. I don't know, in terms of educating colleagues, we focus more on the patients.
Of course. And Wayne Gulliver, he mentions that teledermatology is great for psoriasis follow-up, especially the PASI 100. And he says that he's still liking a person once yearly to check for skin cancer. Yeah. What do you think about that?
I agree. Yeah.
So true, so true. Wayne?
Yeah, fully agree. I already answered in the chat. Yeah,
Yeah, it's a very important point, I think.
this is really balancing where the resources you put into the care versus the outcomes you have. You need to have profiles of patients where you can use a bit less resources and than other ones. And this is what I think the telemedicine statements, I really look forward to reading them, will also be very helpful for.
And Peter, I would like you to give to ask if you have anything to comment on these great lectures today.
Well, thank you, Claudia. I enjoyed the lectures very much. I think it are innovations that we get presented, which have a vision for the farther future, but already we can use them in practice. And I think also it's very inspiring to hear about value-based healthcare. Often in many countries, people speak about expensive medications, but I think we should learn to speak more about valuable medications. And it is for us as dermatologists, I think, very important that we play an active role in not only the insights, but also in the negotiations around costs of disease. I think then the model of value-based healthcare is very important. It is not about prescribing always very cheap medication. For a doctor who exclusively prescribes very cheap medication can be, in terms of value-based healthcare, a very expensive doctor, for you have to create value. And I think we are in a learning healthcare environment where we learn a lot about the innovations offered by telemedicine in its broadest sense. And I think it's really an opportunity to try to incorporate and to get experience also with telemedicine where it is possible really to use it. I had also I'm not been trained. I have not been trained in the past with telemedicine, so I had to do some form of de-learning. I always thought that it is the most optimal to see patients in in-person communication, that it is impossible to have any empathic relationship with video conferencing. But what I learned is that really this is possible, and I strongly advise you really to have an open mind and try to utilize the technologies of today for a better integrated form of healthcare for tomorrow.
Thank you, Peter. I would like to have the last two questions for our speakers, very short questions. Professor Navarini, how do you suggest we do PASI and BSA via teledermatology? Is there a tool for that? This question is from Lira Tumalat.
Thank you. Not a validated one. So, but in our teledermatology service, we're going to be integrating a tool like that kind of proposes the percentage to the physician. But to actually validate such a tool takes more time. There are several algorithms, even published in JADV and so on, that can measure the PASI now on photos. So this is definitely within the realm of the possible, but a commercial service that really offers this straight out of the box is not available, I think, except the photo finder device that is just including this algorithm into its device. But also there, it's just proposing. It's not actually saying, okay, I do it for you.
Okay, thank you. And Joe, from Hamad Haq, do all patients come in with psoriasis only or other skin problems? Do you have different protocols for others?
Yeah, the application of the plus consultation value-based healthcare type, we are only doing this in psoriasis right now. we are beginning to set it up for vitiligo, for atopic dermatitis, and for hidradenitis. But you know what you come across is that there has been a lot of research on outcomes and outcome domains, but mainly in the field of clinical trials. And we do lack some outcome sets to be used in clinical practice. And we put a lot of effort in trying to make one for psoriasis. For atopic dermatitis, there is a nice set for clinical practice, but not for HS, not for vitiligo. So we have to go through that exercise before we are working fully in a value environment, so to speak. And I think what would also be an interesting exercise maybe with IPC is to look for, okay, now we measure the 21 outcomes to measure value in a center of excellence, but why not have a more limited but also very representative set for, yeah, I would say smaller practices, so that they can in a way benchmark their results with other centers. Would be a nice thing to do.
Thank you, Jo, very much. Thank you to all our audience, and I would like to invite you to look at the chat where we have a very short survey that we would really appreciate to hear your thoughts about how this program has looked for you. So please visit us. This is going to be available in our website so that you're going to be able to look at this presentation, both presentations again, and I hope to see you again soon in our next webinar. Thank you, Jo. Thank you, Alexander. Thank you to everybody.
Thank you. Bye.
Bye.
Bye.